Um, welcome everyone to our third last session for the year, or the 8th of the year, I guess, depending upon which way you want to look at it. And this week, we have a guest speaker from many different cities. I have had the good fortune to have known Dr. Peter Cordell since he was a first-year medical student, and he's now in his PGY 6th year in child psychiatry here at Western. And I think before Peter went to medical school, I think he had an interest in developmental disabilities, and that has been expanded as he's gotten further in his education. And I say he's now finishing his child psychiatry fellowship and will be working in the Kitchener-Waterloo area, in part with adults with developmental disabilities. Peter, if I'm not correct, please say so.
Yep. Yeah, no, that's correct.
So Peter grew up in Owen Sound, and then moved to the University of Guelph for university. After being accepted to the University of Western Ontario, he completed medical school here before going to Hamilton at McMaster, and he was in the McMaster Psychiatry Residency Program with a satellite campus in Kitchener-Waterloo, and I think was highly valued there as a member of the team. Peter has been working with me for the last 6 months, and it's having Peter along has been fantastic, and he is an excellent psychiatrist. And so today, Peter is going to talk about something that he and I have talked a lot about, and that's sort of difficulties in making a diagnosis of autism and controversies in that area. So we'll have a lot of time for questions as time goes on. If people want to ask questions, I would prefer people use the raise hand function. We can deal with that later on. But as time goes on, or Peter, if there are questions as they go, would you prefer people to hold it till the end, or what would you like to do?
Yeah, no, I think due to the nature of the topic, it'd be ideal to just wait until the end and then discuss at that point.
Okay, so thank you for joining us, Peter, and welcome, and take it away.
Sounds good. Thanks for the introduction. So presumably everybody can see my slides and there's no issues there, but let me know otherwise. So thank you for the introduction, Dr. Nicholson. So as he mentioned, I'm finishing up my subspecialty training in child and adolescent psychiatry. And so I've been working with Rob for the last 6 months, working in the area of autism diagnosis. So thanks, Rob, and for the department for allowing me the opportunity to present. And also a special thank you to Joan Gardner as well, as participated in a lot of assessments over the last 6 months, but also over the years with both her and Rob, and both have really shaped my understanding on this particular topic. And so, yeah, a special shout out to both of you. So in terms of the objectives of the presentation, so my hope is that at the end of this, you will be left with an appreciation of the imperfect science of psychiatric diagnosis, appreciating we won't go into what could be a whole hour presenting on that, as well as an appreciation of a description of the A and B criteria of autism, which if you don't know what I'm referring to presently, that's okay, and we will get there, and hopefully that will mean something by the end. And I will describe a differential diagnosis of autism spectrum disorder symptoms. And my expectation is at the end that others should be able to as well. And then that should lead nicely into a discussion about diagnostic disagreement, as sometimes different people see the diagnosis in different ways. So I don't have any formal conflicts of interest to declare. The place I wanted to start was kind of what is the purpose of a diagnosis generally, and you can see in the upper right corner the DSM, so Diagnostic and Statistical Manual of Mental Disorders, which is a mouthful, but really referring to mental health issues in a quantifiable way. So the advantages, there are also disadvantages, but the advantages are that it provides a common language, and so a common language of why people present with particular difficulties. And the importance of that is that it provides the opportunity for the common language of diagnosis, but also for directing treatment based on a agreeable diagnosis. And so based on agreement about what a particular presentation means, as well as getting a sense of what prognosis may be for somebody to provide families as well as individuals themselves with that information. And then really to guide research as will continue to be the case indefinitely, as is the nature of science. And so when it comes to individual diagnosis rather than kind of the general concept, really an individual psychiatric diagnosis, i.e. getting a diagnosis, really refers to an individual single expert's professional opinion on the reason why a specific patient, individual client, is presenting with mental health concerns at a particular moment in time. So ultimately, my point is that it's a single expert's professional opinion. And ideally, it is following the standard of diagnosis, which is the DSM-5. What diagnosis is not, which I also think is important to highlight, is that it's not 100% certain and infallible. It's a snapshot in time, and it ideally combines a bunch of different perspectives of people who know someone well, including family, teachers, and the person themselves. But there are limitations to diagnosis based on symptoms, and we don't have lab tests for psychiatric conditions. And so there is some degree of imperfection of this, and that can lead to diagnostic disagreement as well in seeing similar issues differently. It's also not a moral judgment. Providing a diagnosis isn't a moral judgment as to whether or not somebody's distress that they experience from particular symptoms is valid. So it's not making that moral judgment. So who diagnoses autism spectrum disorders, or ASD, in Ontario? So generally speaking, the qualified professionals to diagnose this would be a psychologist, so a PhD, so doing kind of advanced clinical training in this area, but not going to medical school, and the difference in a psychiatrist being somebody who went to medical school and then did advanced training. And so differences in training, differences in focus, and also highlighting that pediatricians are often involved in these types of assessments in child and adolescents, as likely you know. And so how does one come to a diagnosis? So a diagnosis really comes out of a clinical assessment where a patient comes in with their family, as is likely self-evident, but I highlight for a purpose. So the clinical assessment should include multiple different informants, so parent, teacher, and the person themselves, obviously. It should include direct observation and a structured interview, and that all takes time. Ideally, an assessment would also include some structured measures that are validated for autism diagnosis to try to create agreement and consistency in what a diagnosis means. And so the Autism Diagnostic Observation Schedule, or ADOS, is one measure in assessment that is a structured way of testing somebody and testing ideas of theory of mind, somebody's ability to convey social and emotional information, with different tests that are available within that mantra. I wouldn't go through the details of that as there's not time to do so, but the autism diagnostic interview is really a structured way of asking questions related to autism that is more standardized than relying on kind of your clinical dogma. The bottom line, though, is that diagnosis in Ontario is really dictated by an individual clinician's opinion medically, based on whether or not somebody meets criteria. And so ultimately, that is what the diagnosis of autism spectrum disorder is defined by, appreciating that it is defined by the DSM and specific criteria. So likely now Rob is concerned that I have a frog on the screen and wondering why on earth I have put a frog on the screen, and a little bit worried. The reason I put a frog on the screen is that it's a lot less emotionally charged than talking about specific diagnoses. And so I put this on the screen and go into this tangent as a metaphor. So when we think about what is a frog, when we look at a frog, it's pretty obvious that this is a frog. We're probably not going to disagree with each other about that. And what's obvious is obvious. I chose a frog as a metaphor for this because of the ADOS assessment, and that part of the structure is looking at a picture book and having the person being assessed explain what they see in the book and what may be going on in the book, both for seeing if they can share in the emotional experience of what is ultimately somewhat funny, at least I hope, in frogs flying on lily pads chasing a dog in a moment in the story. But otherwise, even if not funny, does provide a lot of information about how somebody conveys with oral language what their perspective is and how they share that information, and the nonverbal gestures that are used during that particular test, as well as others. So I decided to name frog criteria after myself, as do doctors frequently, and appreciating I'm being quite sarcastic here, but also using a metaphor. So the A criteria, based on what I think a frog looks like. So a frog seems to have bulgy, protruding eyes. They seem to be in a sitting posture, and they seem to enjoy eating insects, spiders, and worms. Well, that seems obvious when we look at the frog, but then when we think about other reasons why something might meet these criteria, it becomes less obvious. And so if we're to try to take these criteria and apply them to an alien who has never seen a frog before, and to try to use those criteria to come to the same conclusion, we may run into issues. So an alien may look at this photo and think, holy smokes, that is a frog. It's got bulgy eyes. Oh, but it's not in a sitting posture. So it may be able to get to that conclusion. But what about this one? So this dog over here seems to be sitting. It does have bulgy eyes as well, much like the frog. And this dog may end up eating insects and digging into the dirt if it's hungry, and potentially eating spiders or worms. Seems unlikely, but potentially. So that's a bit of a stretch, but where we could further define things is if we add a few more criteria to try to really iron things out. The advantage of this is it gives us more descriptive value. The disadvantage is that some of these things may be true for other areas, but not for frogs. So we could say that frogs are slimy and green. That seems pretty specific to frogs. They jump really high for their size, and they may repetitively make the vocalization of ribbit. However, slimy and green doesn't necessarily define frogs. Some frogs are not slimy and green. So that may not be as helpful, but if you only need 2 of these, maybe we can still arrive at the same conclusion. Jumping really high for size, this dog jumps pretty high, but clearly is not a frog. And then saying these repetitive ribbit vocalizations, well, what about a parrot saying these things back that sound like ribbit? I had initially thought that maybe there wouldn't be an exception to that rule, but I think sometimes when you try to define things based on a list of criteria, what happens is that you realize that there are other reasons for those problems or for those symptoms. And I highlight that as a metaphor for autism diagnosis, because things are obvious when they're obvious, and things are not obvious when they're not obvious, and require a lot more clinical context. And I think that's where expert opinion is especially valuable. So is this a frog? Well, it looks like a frog, but it's actually a toad. And so I say that highlighting both that I'm not an expert on frogs and toads, but a basic Google search can come up with some distinctions between the two, and appreciating that these are actually pretty similar, but there are nuanced differences, and an expert in frogs and toads would probably very quickly reach the conclusion about what is what. And I think that's where the role of expert opinion can be particularly helpful, is if we just look at symptoms and a list of criteria, you lose context. And when it's applied to something like this that isn't emotionally charged and doesn't mean something for services in the community and for treatment, it does highlight some of the flaws and difficulties that are encountered in this area, I think. And so that's why I chose to highlight it, appreciating that the metaphor also has risks of not landing well, but my intention is to highlight something more neutral. So frogs and toads, an expert in this area would be able to come to different conclusions than somebody Googling these symptoms or kind of going through them and applying them rigidly. So I say that and move to this slide to highlight that this could look like a lot of nonsense. Similarly, Rob, you may be thinking, why on earth did you load the slide up with so much content? And I did so really to highlight that the diagnosis can be remarkably complicated when you look at the symptoms. It can leave a lot to interpretation. And although the criteria are fairly clearly defined, it is confusing when a layperson goes through the criteria, and certain aspects of this are true for many different reasons. And so out of this slide, I really want to highlight 2 things. So one, the A criteria refers to this bullet point here saying A criteria, so the 3 different difficulties here, and then the B criteria being the 4 different ones here. The A criteria, you need all of them to be present at some point in history or currently, and then the B criteria, similarly, you need 2 out of 4 at a minimum at some point currently or by history. So the algebra of autism, as was the equation at the top there, is really ASD is equal to A plus 2B, referring to all of A criteria and 2 out of the 4 B criteria. The fine print of that is that the criteria can be met currently or by history. So it doesn't necessarily mean that somebody has to currently have each one of these criteria, which leads to differing interpretations potentially, but somebody must have some extent of current functional impairment related to some symptom criteria of autism, is really the kind of bottom line out of the DSM of kind of what is the threshold. And it shouldn't be better explained. So in most psychiatric diagnoses, it says the symptoms of this disorder should not be better explained by another diagnosis. And in the autism specific context, it mentions intellectual disability, but I get ahead of myself and we'll talk about that further later. So the A criteria of autism is really referring to these three different criteria of which you have to have each. So verbal social communication involving words and use of language to communicate what you think, what you feel, and your point of view, and doing so in a reciprocal manner. Nonverbal communication for social purposes, so our kind of gestures that we use and our eye contact, other ways of conveying that we are listening, that we are interested, as well as relationship functioning, appreciating that relationship functioning can mean many things. There can be many reasons for difficulty with relationships, most of which are not autism related. The specific type of relationship functioning issues in autism are related to difficulties with understanding implicit rules in social relationships, and we will get to that in more detail shortly. So the verbal social communication involves the spoken language, really to convey socially valuable information. So sharing our emotions and our experiences. And these issues really come up for folks with autism from the listener's perspective and the person interacting with them as difficulty providing the needed information verbally to another person based on that person's context, based on their background, and lots of assumptions that are implicit in social communication, as well as providing not too much, not too little. Lots of things that are difficult to generalize and provide a list of rules about what you should do. And so even if somebody's able to do that and get a list of what you're supposed to do, it would be difficult for most people with autism spectrum disorder to be able to follow such a list, were they to have sufficient language skills to do so. The back and forth conversation building aspect of kind of building in a way where you say, hi, how was your weekend? Oh, my weekend was good. How about yours? There's lots of implicit rules about how we interact with each other, what is appropriate, what is not, what builds in a conversation. Expanding on one's experience when appropriate and when potentially of interest and appropriate relationship context is present. And the tone of voice used in emotion infused. So matching emotion, if I talk really monotonously, which I'm told is a habit of mine as I don't have much of a range of voice, that will make for a boring reading of symptom criteria. However, adding some emotion and enthusiasm likely shows the listener and kind of gives socially valuable information to the listener about what is important to listen to and what is not. So using language for social communication, some parts of this are obvious. So when there's obvious language deficits, the kind of symptoms are fairly clear. So lack of speech, so being nonverbal, for example, on the more severe end, poor comprehension of what is spoken and said, could be also more potentially obvious. And echolalia is often more obvious, where somebody may repeat back something they don't understand. So for example, how is your day today? And then somebody may repeat back day to day when they do not understand what was being asked, or they have difficulty expressing the answer to that question. In terms of more subtle quality differences, these are things that are more kind of the how of social communication and of verbal sharing of information and forming reciprocal communication. Providing appropriate social communication content verbally, as well as the emotions being coded with what you're saying, as well as accurate consideration of what the listener needs and their context. Speaking about a list of criteria to a 3-year-old, I would need to really adjust what I'm saying and probably maybe consider why am I talking to them about the details of this. But I'd likely need to adjust my context to the listener. And if I were to talk about what I'm talking about right now, it's likely to not be understood. Building a shared experience is an important part of what we all do in social communication, and something that is difficult to describe qualitatively what that means, and leads to phenomena of some of these symptoms when you see them, and that it's difficult to list. But qualitative issues can be overly literal interpretations of language, overly literal expressions of language, and missing some of the nuances. So the qualitative experience of a listener may be that in interacting with somebody with autism spectrum disorder, that somebody may have a more one-sided and non-reciprocal exchange, more focused on their kind of restricted interests or something important to them, and may not kind of match the emotional content of what is being said in a way that provides the listener with motivation to listen. And language can often be a means to an end in some ways from the perspective of somebody with autism, of used as a way to request or label rather than to comment and share and build in a conversational reciprocal way. So these implicit social rules are difficult to describe, I think, and it makes it pretty tricky to list exactly what is wrong and then be able to provide context to that when reading through a list of criteria without this clinical context. But rules like when and how to enter a conversation and how to interrupt politely, what is acceptable to say and what is not acceptable to say, these all require lots of implicit learning and observing of others to come to these conclusions. And it's remarkable that as human beings, we do come to learn these rules without being explicitly taught. And for people with autism spectrum disorders, this is quite often a fundamental aspect of the difficulty, is these implicitly not taught rules. So, these can be taught to some extent. You can teach social rules like make eye contact with somebody, use nonverbal communication cues, and these different skills, but then applying them in novel situations is often still a difficulty for somebody. So, you can teach somebody that asking about the weather is a neutral topic and appropriate in some settings, and going and doing that on the subway may not be of preferred interest for the conversation and appropriate from the perspective of others on the subway who may prefer to sit in silence. And so applying general concepts about socializing verbally may kind of miss their mark in terms of how they land. And so it may require lots of conscious calculating and effort that may qualitatively interfere with how somebody interacts. So in terms of nonverbal communication, this is really kind of how not how something is said, but the gestures accompanying it and kind of what you look like while you're saying it. So this gentleman here pointing, we can assume that we're not just trying to look at his fingers, we're looking at something that we cannot see that he's pointing at. And that's something that often is not explicitly stated. For example, having a 9-month-old daughter right now, it's remarkable to see the progression of understanding that I'm pointing at something rather than just moving my hand in an interesting way, and how that develops without being explicitly stated and without having language skills to learn that yet. Body language, how we sit during conversation, conveys a lot about our interest, about respect, about these different things that somebody with autism may not intend to provide a different interpretation to the listener or person interacting with them, but it may not land well at times. Gestures like pointing and waving can be taught, and sometimes you'll see kind of odd things like waving in this way, which technically is what you see when you look at somebody waving to you, but it's not really the socially appropriate way of waving. And so when people try to copy something but may miss the context and kind of understanding of why and what it offers, you can see some qualitative issues like this. Again, teaching eye contact, you can teach somebody to look into somebody's eyes, but the nuances of timing and sustaining eye contact is a really difficult concept to master without knowledge of these implicit rules and without things that can't fully be taught. And that can be really tricky because it can lead to qualitative issues of staring too long, staring in a way perceived as inappropriate or invasive. And so there's quite a few different difficulties in nonverbal communication that come up. So hopefully this isn't your current experience. And since I can't see your nonverbal communication, I wouldn't know anyway, but there you can see several nonverbal indications of this guy kind of going on and losing folks along the way. So hopefully that's not occurring, but I wouldn't know anyway, and we'll still go on regardless. So when do you see this stuff and how do you see it so early in the childhood period, as is the definition of a neurodevelopmental disorder? You would see impairments in joint attention, so sharing, lack of pointing, lack of showing and bringing objects to share in the interest. So in this example, this kid is looking to share in the excitement of sitting in a cup, a massive teacup in a particular outfit, and wanting to share that with somebody, which we may not expect people with autism early in the developmental period to do this in the same kind of qualitative way. So in essence, these nonverbal communication strategies lead to lots of implicit rules. And when you try to define these things, they're quite difficult to put on paper of what it means, and to then apply if you were an alien coming from outer space to try to interpret and apply to an individual human being. You could lead to differences in opinion and different understanding. So the coordination of these verbal and nonverbal skills is really quite complicated. And so, matching your nonverbal communication and verbal sharing to a job interview versus on a date, and how you share your emotional excitement, how you share your interest in the other person without doing so too much or too little, with doing so in such a way where you're showing interest by leaning in, but you're not violating their personal bubble. There's a lot of complexities of social interaction that it's difficult to describe qualitatively, other than to describe that qualitative difference exists, as demonstrated by this little guy in the corner here invading somebody's space. And so these types of difficulties often lead to difficulties with relationships, which is the third criteria of autism. And so informing, maintaining, and understanding relationships. And so the mechanics of relationships, as well as actually the skill of going and securing them. So as is evidenced here, this girl doesn't look particularly interested in the middle in this guy's presentation and whatever they're going on about on the stage, but he seems to be quite happy and missing perhaps the interpretation and some of the things unspoken. And so one can see rationally where relationship disturbances can come up in these lack of understanding of these implicit rules. And so you can also see teaching opportunities as well. So this can be interest related or passivity of not initiating or kind of not being interested in forming relationships. Or this can be more kind of the skills and kind of qualitative experience of the other person and of the clinician of how this person enters relationships and goes about initiating these things. And can often lead to the experience of impaired give and take, like in Dwight on The Office, not to suggest he has autism, but that certainly there is an impaired give and take, and things can be excessively one-sided with Dwight. And so that may not be Dwight's intention, but I suspect that Dwight is also not aware that that is how things are experienced, and it leads to recurrent rejection experiences, as you can see on The Office. So what is a friend? What makes them your friend? Type questions often can lead to this information. As well as understanding what is also impairing in relationships. So does the person have an age and developmentally appropriate understanding of relationships? Can really be an issue for many reasons, such as an intellectual disability, and can really change based on age too. So many considerations. The reciprocal nature of relationships is something that I was hoping to emphasize, as well as the kind of nuances of white lies, context, and all of these implicit rules that are quite confusing. And certainly Dwight and Michael fail at sustaining relationships and forming them very effectively and in a way that would be considered kind of neurotypical. However, the way that Michael qualitatively goes about ruining relationships and having difficulties is very different than the way that Dwight does. And so highlighting that you can have relationship difficulties for a bunch of reasons, but we're talking about these specific reasons of A criteria, and that it's persistent deficits in the DSM. So it's not just trivial and fleeting, it's persistent, pervasive, and sustained, and there is no evidence of good social and communication skills in childhood, highlighting that this is a neurodevelopmental problem and that this is a problem that, if we're calling something autism spectrum disorder, really should be something that is onsetting early in the developmental period. In terms of a symptom presentation, again, early in the developmental period does have the definition in the DSM in this chapter of 12 to 24 months as being kind of the typical presentation of usual symptoms and being must be present early in the developmental period, emphasizing that this is not typically something that comes up in a 16-year-old. Sharing of experience, lack of limited eye contact, these types of things, but particularly language delays, often prompting presenting to care in a younger person with autism spectrum disorder. So there are exceptions to this, but it's important to highlight that these are exceptions, not the majority and not the rule. So it's less common for this subtlety of A criteria. And when it is subtly meeting A criteria, you wonder about if we're describing the same thing as when it's more clear. And why it may be that it's so much more subtle. Is this intelligence related, language skills related, compared to folks who may not have those abilities and kind of endowments that they didn't choose to not have or to have. And similarly, the presentation could be delayed because if somebody is more capable in terms of their intellectual skills, their academic skills, and ultimately their functional skills, that impairment may not really be present until a bit later. But a bit later is more referring to middle childhood, not teenage years and not necessarily adulthood. And so one has to ask, why would it be that somebody would have social skills that onset much later like that? And is it the same thing? Also, one has to ask, where do we define this line? So on this graph of percent of the population on the y-axis, so the up one, the vertical one, and on the horizontal axis, social communication skills. So, you know, there are probably people with exceptional communication skills, better than most, average, somewhat impaired, and significantly impaired. On the left, we have the line being kind of further down, and on the right, we have it further over. it makes a big difference. If we're moving it further over to the right, we're talking about like 15% of the population. If we move it further to the left, we're talking about like 2% of the population. And the distinction certainly matters for diagnosis. And if we're comparing apples to apples, or if we're talking about neurodiversity that may not be impairing and kind of individual differences. So that leads us into the B criteria, which I'll spend less time on. And so the B criteria really refer to the R's, is my way of recalling them. So restrictive, repetitive patterns of behavior, interests, and activities. So the first criteria of this, so you need 2 out of 4 of these. So the first one is repetitive or stereotyped motor movements or language use. The next one is ritualized, rigid, or routine. So insistence on routine, insistence on sameness, inflexible adherence to routines, and ritualized patterns of verbal and nonverbal behavior. Restricted interests. So we're talking about highly restricted and fixated, not individual differences of we all have our preferences. And we're talking about reactivity in a sensory way that is fairly far over on a curve, and where people are having hyper and hyporeactivity to sensory stimuli or an unusual interest in such sensory stimuli. Now, reading through the criteria here, these could be interpreted in a bunch of different ways, but the DSM does provide definitions of these things in a way that I think is quite helpful. So simple stereotypies, including hand flapping, finger flicking, are not necessarily specific to autism, but often occur and could count. Repetitive use of objects like spinning coins, lining up toys could also count. But it's really the qualitative aspect of this of like, well, how much? How often? Is it at the expense of otherwise kind of appropriate playing with toys, of appropriate behavior that would be kind of within normal range? And still, we're talking about qualitative interpretation of these things and something that's more difficult to define with a list. In terms of language, we're talking about repetitive patterns of speech like echolalia, so echoing the last thing somebody said, which is, I put a parrot there just as a reference to kind of reminder of what echolalia is. As well as that there can be many reasons for the B criteria, as in the frog analogy. Pronoun errors of using you rather than referring to self. So I'm not talking about pronouns as discourse presently in a different context. I'm talking about kind of I and you. So you are going to the washroom instead of I am going to the washroom, and kind of errors like that that involve kind of thinking about what the other person needs to hear are common in autism spectrum disorders. Stereotyped use of words, phrases, or kind of odd patterns of using them and the way in which somebody does are kind of repetitive and stereotypes of autism and useful to consider in that context, but difficult again to describe. Insistence on sameness is kind of the second criteria here, as you see in the top corner and above. So insistence on sameness and to the extent of significant distress at small changes. So things like something seemingly trivial, like changing the packaging of a preferred food, not like having your second period change for reasons as a student that you don't agree with, or having a change in your routine during your week that is frustrating to many. And so we're talking about rigid adherence to rules, being quite cognitively inflexible and insistent on adherence to rules that loses social context of kind of implied flexibilities like white lies. Ritualized patterns of behavior, so verbally asking people to repeat things in a particular way for not understanding reasons to facilitate better understanding, but instead for kind of purposes that are not really clear. So I want you to say goodnight in a particular way and to go through a routine in a particular way that is not socially considered appropriate. Nonverbal routines or ritualized patterns of behavior of insisting a particular order of I need to brush my teeth in this particular way with this particular device. So restricted interests ultimately refers to a very specific and fixated interest, much like in the show Atypical. This gentleman's insistence on talking about penguins, which is an unusual but potentially socially appropriate in very specific contexts, but where it becomes quite abnormal is the way that he insists on talking about it in many different contexts and comparing things to it that creates some social difficulties for him and may not pick up on the needs of the listener. So the intensity and focus and the abnormal quality of that is something difficult again to describe. So examples could include strong attachment to an object like a pen, a vacuum cleaner, things that like we're not generally attached to and don't kind of write out timetables for the purpose of just enjoying it. we would typically do so for a social purpose, like getting a good grade on a timetable and practicing it. So the sensory reactivity is also potentially difficult to describe. So the emphasis is on extreme, excessive fascination, indifference to pain, heat, or cold. So fairly dramatic terminology. And again, thinking about where on that normal curve are we? Are we further to the left or further, or are we moving into kind of normal variability and kind of learning to understand different people's sensory preferences? And so these are talking about very extreme responses to specific sounds, textures, and those types of things. So I can see I put or textures twice. Fascination with lights or spinning objects, but not for social purposes. So extreme reactions to rituals involving taste, smell, texture, or appearance. But again, it's difficult to define. And so the symptom presentation typically is there in early childhood, but also there in early childhood is normal development of most kids have strong preferences about these things in early childhood, and that's part of like asserting who you are, what you like, learning about the environment, and getting a sense of self. In middle childhood is where this may differentiate more from normalcy of these kind of rigid adherence to rules, strong preferences, and playing in an atypical way, where it's not as clinically obvious initially in a younger child. So these are where this starts to kind of separate out, where middle children are becoming more and more socially invested, in the social rules kind of add in complexity. So these usually continue as an adolescent or adult, but in kind of the exceptional cases, there are cases where this does not occur and where somebody may no longer meet the criteria, and they still are appropriate for meeting a diagnosis of autism pending current dysfunction. So the spectrum itself refers not necessarily to the spectrum of a black and white binary of high functioning, low functioning, but refers to that there can be very significant differences in how somebody presents in the manifestations of autism spectrum disorder. So for example, people can have very different symptoms, and they can also have very different functioning. So this is meant really to refer to both severity, so high functioning, low functioning is often the common discourse, but that severity is really meant to refer to level 1, 2, or 3. So how much support does somebody need based on A criteria and repetitive behavior and that aspect, but also the symptom differences considering developmental level. So if somebody has an intellectual disability and their developmental age is younger, that needs to be considered in how they're presenting. Is it appropriate actually for their social understanding to be impaired in that of the younger child and conducive to otherwise understanding them within their intellectual disability kind of diagnostic paradigm? Or is it something extra and excessive to what you'd expect developmentally? Developmental also refers to really where they are in terms of time and development as well. So things can also change based on current supports and historical supports and treatments. So people can gain social skills and learn these things, but again, people typically do have qualitative difficulties still in applying them to novel situations. I highlighted this not to be doom and gloom and highlight a storm coming and a very negative prognosis, but to highlight what it says in the DSM about their intended use of the DSM-5 criteria for autism spectrum disorder, and to ensure that we're applying it the way as intended. So poor prognosis in the majority is what is listed, with a small minority living and working independently, and requiring a very significant amount of support to be able to live independently if appropriate, as well as adaptive function mismatch compared to intelligence, where if somebody has an intellectual disability, you'd expect that their adaptive functioning is more in line with their intellectual capabilities, whereas in autism, often there's a pretty discordant match between those two, or a mismatch. And so things can be pretty confusing about why somebody adaptively functions poorly, whereas their intellectual skills may actually be better than one would assume. And so there can be lots of misunderstandings because of this, but ultimately what I wanted to highlight is the poor prognosis in the majority is what the DSM is intending to suggest that we're diagnosing. But they also do highlight that there's a better prognosis group, likely of which have superior language and intellectual skills to be able to function in society and have these adaptive skills of social functioning, of occupational functioning, holding a job, living independently. And when I thought about this, this really highlights the importance that we place on language skills and intellectual skills in social communication and in ability to participate socially in society in terms of workplace and that type of functioning. So those issues really highlight this graph again of what is the threshold. The threshold in the DSM is current functional impairment. So although you can have symptoms in the past, either A symptoms or B symptoms, and you don't have to have all of them presently, it does highlight that you do need to have current functional impairment. So we're not talking about people who currently are functioning without any impairment. We're talking about some sort of significant difficulty that is resulting in clinical care needs and support needs. And so that really defines kind of where are we on this graph? Are we lower? Are we higher? Where do we move that, left or right? And different people have different perspectives on how they interpret functional impairment. And I think that's part of the factor in differences of opinion. And then in terms of current symptoms, you do have to have some sort of autism-related symptom causing that impairment. So it can't just be that you're impaired in relationships for other reasons or another diagnosis. It has to be related to autism in some meaningful way. And so how is clinically significant dysfunction defined? The definition can be interpreted, but socially, occupationally, and then other important areas. So again, leading to some differences in opinion potentially. Not better explained by criteria really refers to these symptoms can be present, but not due to this particular mental disorder if it's better explained by something else. What the DSM highlights is intellectual disability and global developmental delay. So for folks who have not been yet tested or maybe under age 5, and it may not be fully clear yet, being global developmental delay and intellectual disability, the more accurate kind of term looking ahead and thinking about prognosis. So this brings us to differential diagnosis. Now, in a perfect world, I'd have 2 hours to give a presentation like this because there's so many nuances and I'd love to go into the history of diagnosis and these types of things, but we obviously don't have time for that. So I will kind of go through this part relatively quickly. So differential diagnosis for autism spectrum disorder really includes social communication disorder, probably one of the top considerations. So this is essentially a criteria. So that social qualitative issue and relationship difficulties is described as social communication disorder, but they're not having the B symptom. So that would be the difference. I'll go into more detail. Language disorders, if you can't use language, it makes it difficult to socially communicate and function. And so that could potentially present similar to autism spectrum disorder, but you'd expect that somebody with a language disorder most likely would be able to provide nonverbal communication, as well as an age-appropriate understanding of relationships and potentially have less B symptoms, but it is well reported that people with language disorders do have some of these B symptoms too. So not necessarily specific to autism. Intellectual disability is probably one of the bigger ones of if you are globally impaired and functioning more at the level of a 7-year-old, but you appear physically like you look like you're 18, your social skills may be quite limited by comparison to your peers, and you may interact in a qualitatively off way and have developmentally immature relationship understanding, but the reason why is important. And so is it that somebody has excessively symptomatic A and B criteria of autism in excess of what you'd expect for an intellectual disability, or is it what you'd expect, keeping that in mind with an accurate understanding? ADHD, interrupting people in conversation, going off tangentially, not appearing to listen, that really can facilitate a lot of social skills difficulties and qualitative issues that people could report. And it is well reported that there are social skills deficits in ADHD as a group, not necessarily in the individual, as well as considering the common comorbidity with oppositional behavior, also not particularly socially advantageous, or considering the theory of mind and needs of another person. And kind of the argumentativeness and losing perspective on things can really be quite a difficult behavior that, again, how you define that and what you call it, and if it's better explained by ADHD and ODD is another consideration. Social anxiety disorders, is it that somebody's social skills are inappropriately low for their age because of worry and because of lack of exposure to social opportunities due to avoidance? Or have they always had a skills deficit in this that predated their kind of middle childhood, late childhood development? The distinction being important. People with autism really should be having these types of difficulties in social qualitative issues, forming relationships, well prior to when you start to become increasingly aware of others' perspectives and your social standing. OCD, in this setting, people often have difficulties with repetitive or ritualistic behavior, but it's for a different purpose than maybe the case in autism, but one can see where there may be B symptoms present. And if somebody's spending a lot of time on these things, it could result in less opportunities for social skills development. So those are several considerations. I didn't mention generalized anxiety, but I should, given I put an acronym. So generalized anxiety really referring to generalized worry about a wide range of topics, but often that people have a very significant preference for routine and become increasingly anxious and upset when routine is not followed and something unexpected happens. So if you consider that most people with anxiety disorders have more than one, and that social anxiety and generalized anxiety go together frequently, you can see how this could potentially present in an adolescent with concerns about social skills impairment and potential autism. Personality disorders, I won't say a ton about, but there are potential reasons that are related to personality disorders that could present in the setting too, as well as kind of normal individual differences and how much do we pathologize unusual social behavior and frame it as a clinical issue versus acceptable, eccentric, and different behavior than the norm. The social communication disorder is the one that I'm going to go into the most detail with here and then move on. And I'll provide kind of these slides as a reference afterwards, appreciating we won't go through all of the detail and I more talked through them there. So A criteria plus less than 2B criteria really is the algebra for social communication disorder. And this is useful in terms of considering that social communication can be impaired for reasons that are not autism. The most common comorbidity and potentially contributing factor to this is a language disorder and also ADHD. This is most useful in the context of comparing autism with social communication disorder. So the difference really is that both have A criteria of this kind of qualitative deficit in skillfulness socially, but the social communication disorder doesn't require the extent of relationship dysfunction, and similarly doesn't require B criteria, whereas autism does. And so you can see quickly where this may be appropriate. You can also see quickly where social communication disorder may be inappropriately diagnosed in somebody who did have a lot of B criteria when they were younger, and so should meet criteria for autism spectrum disorder. Intellectual disability, language disorders I've covered, social anxiety disorders similarly, so I'm going to click through these for time purposes. But the nuances of this I highlight, that expert opinion really does provide context about this. Knowledge of the DSM allows one to really interpret why somebody might have a list of symptoms. And if things were as simple and clear as questionnaires, why on earth would you need to see a psychologist or psychiatrist? If you could just literally do a questionnaire and understand your diagnosis without any sort of accuracy and reliability concerns, you know, it would certainly be a lot less expensive as a system. The problem is it removes context, it removes expert opinion, and there is some value in that, I think. And the main value may be context and broad understanding. Frogs versus toads may be easily defined when you're looking at a comparison, but when you look at an individual removed from context and you're not an expert in that area, it can be actually fairly difficult to define. So a case in brief that we will kind of rip through here is really to highlight one particular concern that came up. It's anonymized. This isn't the specific case necessarily. So a 14-year-old trans boy came into clinic after a psychiatrist that they'd been seeing for multiple years had referred them because this individual had asked to get tested for ASD because they felt that they had it. The psychiatrist who knew them for years had formulated their difficulties as ADHD, ODD, and social anxiety. And they had initially presented with inattentive and hyperactive symptoms brought forth by the school as a concern, as well as by parents. They also previously saw a pediatrician. They also previously saw a psychologist for a psychoeducational assessment. And none of the previous clinicians raised the question of autism spectrum disorder. Previous diagnosis of ADHD was an agreement between all three clinicians. So there was pretty good reliability between them. Similarly with anxiety symptoms with differing opinions about ODD. The person responded well to stimulant medicine, which would be typical of somebody with ADHD as well in most. And their developmental history wasn't typical of autism spectrum disorder. So they didn't have language delays, but doesn't necessarily mean they don't meet criteria. They could have been a higher functioning sort of folk who the issues didn't become clear until later. But they did demonstrate a wide range of interests. They were able to play with others appropriately in preschool. And the comments were really about emotional reactivity when frustrated, low frustration tolerance, anger, but still able to form friends, but perhaps a qualitative impairment in that way where it could become difficult at times. They were described as shy in temperament, and they became gradually more withdrawn over elementary school with reports of bullying and frequent rejection experiences, but not related to social skills specifically. And report cards commented on typical ADHD symptoms of the inattentive variety, of interrupting, leaving their seat, organization difficulties, and missing deadlines. So again, really the clinical history matches this diagnostic assessment by others in the past. And yet the person also highlighted that their purpose of coming to the assessment is, quote, I know I have autism. And when asked about like what they were hoping we could offer, it was more about diagnosis. It wasn't about offering anything specifically, but more that they already knew. So they had highlighted, I'm neurodiverse, and that this is consistent with their friend group. And they highlighted some of their long-term relationships with a shared interest in Minecraft. So I think that this really highlights some kind of counterintuitive information that you'd expect or that you wouldn't expect in autism. And it also highlights that this person sees things differently about interpreting those criteria. They prefer a quiet environment, which they felt was a sensory symptom of the B criteria. And that when the environment is busy, they become overstimulated and distracted. So the parents themselves did not actually report those things on developmental history or currently from their perspective. It's not mentioned by the school. And the parent again describes this range of interests as well as long-term friendships. They also describe shared experience, parallel and imaginative play, as one would expect in a typically developing child, and fair eye contact and understanding of nonverbal communication. So the patient instead responds, though, that they actually disagree and that they think that they have no interest in other people and that they don't like getting to know them. But when further questions are asked, it's because of concerns about judgment. They highlight that other people are not in keeping with them because they are, again, neurodiverse and on the spectrum, and so are their friends. And so that's the reason for their difficulties from their perspective in liking other people and spending time with them. But they do describe these shared interests and ability for back and forth conversations, humor, and kind of the pragmatics of what goes into relationships. So avoiding eye contact, not observed throughout the interview, but initially, and lots of comments of I don't like eye contact being made to let you know why, which implies some degree of theory of mind and communicating why they're doing the particular nonverbal behavior, nonverbal communication behavior. And they spoke about a range of topics as well and used gestures appropriately. So they weren't interested in our formulation and became argumentative when diagnostic feedback was provided in the second time meeting them, spending about a total of 3 hours with them. And they were quite insistent that I know I have it, I know I have autism, and I looked up the symptoms. They described 60 symptoms that they found on Google that I'd say are fairly non-specific, and they argued about this not meeting criteria as being because they're masking. So I felt in this situation that part of the search for meaning was really validation driven. And I think that there could be several potential reasons why. The masking concept is mentioned in the DSM, but not as described by this person and described in some newer literature, and has become potentially a controversial subject. And so I think masking really is meant to refer to learning to suppress repetitive behaviors, not specifically to mask kind of any symptoms of autism and yet still meeting criteria. And so I think there's some misunderstanding there. The model of kind of this transaction of, I'm coming to you for a diagnosis, you need to give it to me, and sort of rejection of expert opinion at the same time as being a challenging dynamic. And later this person came back after not getting this diagnosis from us, and they got it from another clinician who was the 5th person they'd seen. And they said, I finally got this diagnosis and I always knew I had it, implying that we were wrong. And so I guess there was no follow-up from that assessment ultimately with that other person who diagnosed them. And yeah, I wondered why, appreciating I've gone a bit longer than I had intended to by about 5 or 10 minutes here. So I guess the question though that I will ask before I open it to the group is the 5th clinician correct? Is it a 20% inter-rater reliability for autism spectrum disorder that we should expect and that everybody else is wrong, the 80%, or is it the other way around? Does it speak to the reliability of diagnosis, or does it speak to individual differences in how they apply it? Is it okay experts don't agree? Do they always agree? No, they don't. However, most psychiatric diagnoses have about 80% diagnostic agreement between people seeing the same person. And so one has to ask the question of why. Could it be individual differences? Certainly arguing loudly with more words is probably not the way to solve this problem. And like reflective practice, CQI projects of like how we're applying this in supervision, likely to be helpful issues. But should we question the diagnostic reliability? Should we question social shaping and external pressures for services for autism? And are we interpreting current functioning issues as a difference in how we view this particular paradigm of what is significantly impairing and dysfunctional? I think it's that we're interpreting the not better explained by criteria differently as a significant factor, as well as external pressures. But again, considering that differential diagnosis and how broad it can be, I think is important with some degree of humility to appreciate that we can see things differently, but there's also this multitude of reasons for differences. So my hope is that I met these objectives and that you know what I'm talking about A and B criteria now, if you didn't before, that there's some operational aspect of that where you can put that to practice, and that there's some appreciation of like humility in psychiatry and the imperfect nature of diagnosis, as well as a recognition of the differential diagnosis for autism and some of the possible contributing factors for disagreement among clinicians. So my conclusions I won't go through because I think it's more important to hear feedback if there is any, or differences of opinion. But I think highlighting experts do disagree, and that's okay, is an important consideration. So maybe I'll open things up, Rob, and hear some thoughts, or if there's questions.
So thank you, Peter. That was a really nice sort of review and discussion of some of the areas. And I think, as you highlighted, I don't want to say we're stuck in psychiatry and psychology, but we don't have the luxury of biological tests. We can't do MRI scans to diagnose things. We don't have any blood tests at this point in time. But so let me ask you what you asked about, the person who ultimately diagnosed that one person with autism, the case described. What do you think? What do you think about that fifth psychiatrist and whether they were right or wrong? Yeah, you're on mute still.
Thanks. I was going to keep going. So my medical opinion, based on the DSM-5 criteria, is that they don't meet it. And so like I disagree diagnostically. I'm not sure exactly why they have a different opinion, because it wasn't clear necessarily in the note to really interpret with clarity and to try to see where we disagree. But I know from speaking with one particular clinician who sometimes sees things differently, that it's a difference in kind of formulation of what it means to have autism, and not necessarily in terms of application of the DSM criteria. It's more of kind of a clinical schema of what is autism and what is a particular diagnosis that may guide the difference of opinion. And so I think that there's some adherence to the diagnostic criteria where I think that there's some errors in that way of how it's operationalized. But I also think that they also fundamentally see it as a different, there may be some disagreement about the criteria as used in the DSM, and whether or not that's valid as part of the reason for disagreement for them specifically from a conversation.
But well, I agree. And, I think that part of the difficulty is that the criteria has changed with each iteration of the DSM. And so, which I think says a lot about our difficulty defining it. And I think your point about the whole, I think what I've seen a fair bit is kids with different kinds of problems. People aren't really able to come up with a definitive diagnosis. They say, well, I'm not sure what it is. I don't know how to explain for it. Therefore, it must be autism. And I don't think our diagnoses should be diagnoses of, I don't know what it is, this is what it must be. I think there should be some positive evidence for something, as opposed to just a lack of evidence for anything else, or uncertainty about anything else.
Yeah, I mean, we've discussed this, so I agree with you on that point, and I think like the multitude of different reasons why somebody could have different symptoms, I hope is not lost in the presentation as well. Of there could be a lot of reasons, and I think like there is value in expert opinion in providing that context and understanding of these other reasons. Because if I were to be a person with no experience in psychiatry and just look at the ASD criteria, I think it really truly would be pretty difficult to interpret and apply to myself or to a family member or to a specific clinical situation without context and experience. But the diagnostic disagreement, I think, is a slightly different area too than kind of social understanding of autism too, but probably shaped by it as well, in that different people see the diagnosis differently. And it's tricky when different people diagnose it differently, and then that really shapes how the diagnosis is viewed in society as well, how it's represented in media, and how different clinicians see it too, since that you'll be exposed to that too, and that will create your schema of what autism is, regardless of DSM criteria. So it would be nice if it was easy, but it's not.
Well, I think that, the surgeon say if it was easy, anybody could do it. And I think that's the difficulty part with the internet and people looking at rating scales, that frankly, if it was just a matter of checking off boxes, then say a motivated high school student could do a good job. But it's obviously a lot more to it than that. All right, other thoughts or comments about what Peter has presented or about his description of things? And I think we will call this a safe environment. And so I think that, as Peter said, there's a lot of disagreement about autism, and we all, as much as we try to be objective, it's impossible essentially. And so if people disagree, please feel free to say so. I mean, I think this is an opportunity to discuss these things we may not always get as a group.
Yeah, I will second that.
Dr. Pryor, why don't you, and welcome, Catherine, just unmute yourself. So Peter, just for your benefits, of Dr. Pryor has been the clinical director of the program, autism program and the OAP program at Thames Valley Children's Center, sorry, TVCC, and has worked there for a number of years and has been in the field for a number of years as well. So Catherine, you just have to, actually you are unmuted, so go right ahead, Catherine.
Thank you. Yes, I really enjoyed the presentation, and I think you made some really excellent points. And I really resonate to the part about the differential diagnosis, because I find that is often missed. And I guess my training and background, which is some time ago now, but always included the intellectual assessment, which was also very valuable for also evaluating the different criteria around autism. And I think that often, even in running a current clinic, that we have done that where there is intellectual disability evident or GDD from various rating scales, that those things are not being identified. And I find also that there's other situations where differential diagnosis are not even considered or noted in the note or the report that shows them as considered and ruled in or ruled out. And I think that would certainly help to have, and that's been a practice I've adopted sometimes if I'm ruling something out, like ADHD, which may reflect, more limited cognitive abilities a person has, and the parent sees them as inattentive, and they may be, have high activity level because they're just not making sense of what's going on around them. And so I feel like that those things are challenges, because it would be really helpful to have those things identified within a clinician's report, like what other measures were done, what other diagnoses were reviewed, to be clear about the identification when there is a GDD evident there, so that the parents really understand that and how that also can relate to the behaviors that we see and the impact on social relationships, on communication, and all those features, repetitive behaviors. And I think that there's been a little bit more of a reductionist view to the diagnosis than there was previously. So if it's not autism, what else is it? And I think sometimes that's not happening either, that it's either it is ASD or it's not ASD. And I think the families really need more clarity sometimes. So I think that your points are very nicely articulated around really looking carefully at that criteria and looking at how some of those things can overlap in other conditions and where they would differ. And I think it would be information that would be very helpful to other people.
Thank you for the feedback there in your perspective. I think the point about kind of like autism present, yes or no, can be a really tricky one, because I think like it's a bit of a meta about, like, as it's perceived, at least, it can be a meta about like whether or not somebody's suffering is valid and real and whether or not we recognize it. And I hope in the case example provided, appreciating I kind of ripped through it fairly quickly, that like the message is not that the person's not suffering and not having any functional impairment and that there's not a difficulty. It's just that of a different variety. And to your point about the kind of diagnostic formulation and documenting it, I think it would be remarkably helpful to be able to read somebody's note and consistently see that, because it would really allow you to better understand of why there's a difference of diagnostic opinion. Like in the particular case I'm referencing with kind of some changes and whatnot, it would be really helpful in speaking with the person directly. You got some context of it, but it would be nice to have that consistently documented in balance with our time demands and professional demands and these different things as well. Yeah, we could talk for a long time about various things you said, and thanks for your feedback.
And so Dr. Ninen has decided to wade into an area that is fraught with potential complications. So, I mean, Ajit, are you comfortable talking out loud? So I will read what Dr. Ninen said, and then I will, or would you prefer, Ajit, are you okay with speaking out loud about it? I don't know how to interpret a lack of response. So let me, oh, sure. Okay. So Ajit, if you want to put up your hand, then I can unmute you.
Okay. Yeah, I see the comment there as well.
All right. Now, Ajit, I am allowing you to talk. So all you have to do, Ajit, is just unmute yourself. Yep. There you go.
Okay.
Yep.
Yeah, sure. So, like I think the point that I was going to make is that to some degree, there is an incentive, if you will, for certain diagnoses to be provided because either in actuality or by perception, there is a difference in the ability to access funds or services with certain diagnoses over others. So that could lead to more of an incentivization within the system, particularly when our system is a diagnostic-based system, as opposed to other ways of organizing the system. So that sort of leads to some complexities for diagnosticians to make the diagnosis, particularly with that additional pressure that may exist that patients and families may be aware of as well. So that's, I think, one complicating factor. Another may be around what seems to be occurring in society as of late, and that is an emergence of growing developmental challenges within adolescence, of really solidifying identity. And I think that's sort of a topic on its own, like what is sort of causing that phenomena. But it certainly appears to me to lead towards embracing other diagnostic identities, entities rather, that relate to identity, including social acceptance, or the need to pathologize particular experiences, to externalize the source of those difficulties instead of working it through as part of typical adolescent development. And that may be another sort of attraction to a diagnosis like autism. So more of a comment as opposed to a question.
Yeah, I think it's a comment that can socially build reciprocally as well. Like I think one of the reflections I have about the second point that you made there is that one, developmentally normal to kind of figure out your sense of yourself, and part of something that we all do in adolescence to try to gain a sense of yourself, of where you stand, what you're interested in, and come to that type of conclusion. And in doing so, to have some rejection of potentially parents, of authority figures, and that type of like normative phase of development considerations. But also that the diagnosis of autism seems to intersect with that as something societally seen as a more valid reason for one's distress or difficulties compared to other diagnoses. Like I'm not entirely sure of the rationale of why autism spectrum disorder would be seen as a more validating reason from the perspective of an adolescent than ADHD for their difficulties in social skills or social relationships, and why it would be such a remarkably more effective sense of self and validation fulfilling diagnosis. But it does seem to be something that is observable and difficult to discuss in a way that is not perceived poorly and perceived as invalidating, but seems to come up frequently clinically in some of these diagnostic assessments. I'd say has been in the experience I've had. Yeah, and I think that speaks to probably the discourse about autism in society compared to other diagnoses. And probably social communication disorder, intellectual disability don't get spoken about, would be my opinion, in a similar way in society, and similarly with ADHD to the same extent. And I wonder about how that plays for adolescents in interpreting what is out there, more directly, and kind of blurting out what is otherwise kind of implicit in society in the discourse about the topic.
I wonder, Peter, personally, though, if people sometimes see ADHD as more willful behavior and as bad as a badly behaved kid, as opposed to somebody who just can't help themselves in a way. So let me ask you, why do you think it is that we are having this discussion about autism, but yet we don't seem to have the same discussions about ADHD or OCD or things like that?
I think for exactly the reasons that Dr. Ninan suggested around like service in the community, like autism spectrum disorders do have a difference in how they dictate service in the education system in terms of the provision of funds to family, and kind of not secondary gain in terms of a judgmental or devaluing way about why people may perceive a diagnosis as helpful, but secondary gain in that like there really truly are kind of secondary reasons that are helpful to people of having a diagnosis of autism specifically that don't come with ADHD. And similar to your interpretation about the kind of controllability of behavior and acceptability of behavior, I think that is a matter of kind of discourse that is out there. And I think that adolescents may pick up on that and blurt it out and explicitly state it, what is sort of implicitly discussed otherwise about that part.
But I think also one of the difficulties with autism is that it's difficult to define the social difficulty, right? And I think this has always been the problem, and why perhaps the diagnosis has changed radically with each iteration of the DSM, is because it's, I think, remarkably difficult to define social differences in a way that doesn't just mean somebody with no friends or somebody who has difficulty maintaining friendships. And I think that's a very, very difficult thing to be objective about. Whereas I think, if somebody's bouncing off the walls, we can all be sort of objective about that.
I totally agree. Yeah, that is definitely a component.
So, all right, Dr. McLean has a question as well. So, welcome, Dr. McLean. And if you could just unmute yourself.
Thanks for the excellent presentation. I've been involved with you before in terms of working with some families, and I love the way you have insight into some of the issues and how difficult it is. So I just wanted to say out loud first. I'm going to just make the point about, we try really hard from the perspective of diagnoses, no matter what they are, including ASD, to use the evidence-based perspective and really trying to go along with what's going on. But I mean, no matter how you look at the issues about ASD specifically, I mean, there's the science, but there's the art of diagnostic, and you really need to have that experience of different children, youth and adolescents, of how they can present, what the kind of difficulties they can have if they're along the ASD spectrum. How often do we see kids referred from school-based areas where, I mean, obviously they have ASD, we get told, because I have this kid and this kid in my class and they have ASD. But it comes back again to which clinician, and I'll say it out loud, what their experience clinically has been. It's important for those working in the field of diagnosticians to be able to say, I have experience, I've seen a breadth of, different children and youth along the diagnosis, because until you get that breadth, you don't really understand it. And, and we can even handpick which clinicians, if you really want the diagnosis, where you can go. And that's really because, and it's not their fault per se, but rather that they don't necessarily have the breadth of experience that others have. And I'll just say it that way. And also there's the perception, and just like Rob was saying, that if you have a diagnosis of autism, it's easier for you as a parent to be able to say, oh, that's my child's doing this because they have autism. And everybody knows autism, it's a neurological, genetic-based problem. And so obviously it's nothing to do with anything, about how we handle our child. And it gets them off the hook. And they feel that makes everybody feel better. Whereas the other diagnoses can be very, very difficult for families in terms of explaining why their child is having so much difficulty. And so again, it's always important to know why they want the diagnosis. What do they think the diagnosis may be helpful for? Because there's a lot of misconceptions out there. So I just wanted to thank you again, and I just added my 2 cents there.
Thanks. I appreciate you adding that. And like to your second point there, I think like it's tricky with heritability of mental disorders, and that there is, I mean, there are meaningful differences, and some areas are more heritable and interpreted as more biological than others. And I think that's a incredibly helpful development over the last 70 years in the field of autism, obviously, of not blaming mothers for cold parenting and that type of thing as the reasons why. And also, I think like sometimes the heritability of some of these other issues in societal discourse, at least on these topics, get missed, and that it's pretty high, like heritability for ADHD, quite high as well, but interpreted differently in discourse. The first point you made there about the individual clinicians and diagnosing it and like breadth of experience, and I wonder about why it is, and I presume, and perhaps I'm making many assumptions, is that those folks are not often attending these types of rounds, and they're not often having this discussion with colleagues and encountering different opinions directly. And
no, it's not that we don't invite them.
And so, no, I agree, and I'm not trying to assign blame or
no, but we're trying to
anybody,
open it up for everybody, but they don't partake of those opportunities necessarily.
And I'm not sure what kind of personal factors, and aside from systemic reasons, like I think there must be some factors that dictate somebody's willingness to participate in these types of things, and also kind of, I mean, perhaps that is a factor in why diagnosis is inaccurate, that like there isn't participation in departmental rounds and these kinds of things where you're exposed to different opinions, and there's kind of shared understanding and building of these things. And yeah, it would be nice if it was an easy problem to address, but it's obviously not. And it's a problem that we're all aware of, but isn't easily solved as a system or as an individual clinician either. Yeah,
I wonder,
it's a tricky one.
I wonder, Peter, if it goes back a bit to what you're talking about, humility, though, right? Being willing to step back and say, what is it possible I made a mistake here? What was the error that I made? And I think that's where sort of discussions like this are really valuable. And I think sometimes, and what I find valuable is in working with other clinicians is sort of getting different perspectives and on how, maybe I'm viewing things differently from other people, and what do they see? So ultimately, I think perhaps Dr. Ninan has asked the question that matters the most. We know that I think among people, who are trained using ADOS anyway, and ADI, the reliability is fairly high. But even in other groups who may get extra training in autism, among child psychiatry or pediatrics or pediatric neurology, we still don't always find agreement. So what do you think we need to do to change that? And I don't think we're ever going to get 100% agreement on the psychiatric illnesses, but I think with autism, we have a wider range perhaps than we do with other things. And so what do you think needs to change?
Yeah, I mean, I think like if we're at about an 80% rate, and we're pretty similar to other psychiatric diagnoses, then some radical acceptance to apply a DBT principle of accepting that different people can see things different ways, and there's not much we can do about it. But given that I think the rate is significantly lower than that, and there are these kind of efforts to establish instruments to improve reliability, I don't know that I have like the answer, because I think that there's these secondary gain factors, not to imply judgment, but to imply kind of that there is a gain secondary to the diagnosis, factors that really dictate part of that probably, as well as kind of humility and individual characteristics. And then I think the language in the DSM, like the updated revision that they're doing right now, I mean, there's very minimal change in autism spectrum disorder, and the change that they did make, I don't think really helps. Like it says, that somebody should have all of the A criteria, but I think most people interpreted that anyway. It doesn't change it doesn't add to the differential diagnosis section of it, which I think the DSM actually could do a better job in describing a wider differential. It really just states language disorder and intellectual disability / global developmental delay. And so in the absence of extra clinical training programs and reflective practice sort of forced on you in attending rounds and getting supervision every once in a while as part of your practice maintenance, I think like the actual diagnostic criteria themselves and how it's described, I think that area of differential diagnosis could be markedly improved. And I don't think it's an easy thing to improve and whatnot, but I do think that it's inadequate the way there's not a wide differential in there.
Well, and I think some of the revisions, I think in the text revision of DSM-4, the only change in the pervasive developmental disorders was a comma was moved in one of the definitions or something. And so Peter, you're saying in the DSM-5 revision now there's a more explicit statement that all 3A criteria have to be present?
Yeah, so it says all of rather than the following. So it says all of the following have to be present rather than some, like where before you could interpret as not necessarily all of the A criteria. Now it makes it explicit. I think that's not the problem though.
But do you know anybody who didn't
interpret the problem?
Do you know anybody who didn't interpret it as all 3 had to be present?
No, I don't imagine many do.
I mean, yeah, that just seems like it's missing the forest for the trees.
And they could, that is something meaningful that could be changed that I think would help when people are studying for exams and trying to like learn about autism in psychiatry. And like, I think that would make a meaningful difference to have a wider differential. Because stating global developmental delay, intellectual disability, and language disorder in that section and not commenting on social communication disorder, not commenting on social anxiety, ADHD, like there really is a missed opportunity there for potential learning for people, because that is the standard we're held to. And so like it is taken fairly literally. And I think that could be meaningful, but I'm not delusionally hung up on if they change the DSM differential that practice will necessarily change, but I think that could be one modifiable thing.
Dr. Pryor, your hand is up. I can't tell if that's up from before or if you had something else to say. Did you have, was there something else you wanted to ask? Oh, you took it down now, Catherine.
Oh,
good. One thing I would add, though, just based on this discussion, which I also think would be really helpful, is, and you alluded to it with the case example that you provided, was the fact that so many different people had agreed, and then somebody has a different diagnosis. And what I've often found over the years is when you get somebody who you feel has done a reliable assessment and not found ASD, and then somebody else does, but they don't even reference the previous assessment. And so I would be thinking, okay, what's changed? What really looks different? And it speaks to that diagnostic variability, that it isn't evenly distributed. And I think that that's part of it, because to me, if I was going to be changing a diagnosis that was already ruled out or ruled in, I'd want to know what is now functionally different and in what areas. So why is it, valid or should be changed? And I feel that sometimes that's also a missed opportunity to be more reliable, because then we can understand developmentally what's changing for the person and in what areas. But I feel sometimes there's perhaps an intentional lack of inclusion of consideration of the previous diagnostician's results. And that needs to be, I think, increased.
Yeah, I think if I were to think of my own practice and I were to see somebody who I disagreed with 4 previous experts, and let's say I disagreed with Rob, I disagreed with Dr. McLean, Dr. Ninan, and Dr. Pryor, I wonder about my humility in terms of feeling so confident in my own opinion and why it would be different. And I'm not sure why and I'm not ultimately sure of the reasons why maybe that either happens and it just doesn't lead to a different result, or if that's not happening and the individual factors that may play a role in that. Because really it should be kind of an illuminating question when presumably people are coming in and mentioning or complaining about their previous experiences of not getting this diagnosis they feel they have or their child has and is pursuing another assessment. I mean, yeah, it would be nice to be able to hear somebody's perspective directly on that. Appreciating that to imply that it's personal is implying some sort of personal attack there, I suppose, but I think there have to be some personal factors there too, given that we probably wouldn't all contradict each other's opinion without careful consideration as to why we may see it differently.
Or at least taking it into consideration.
Yeah.
So Dr. Ogilvie has asked, I think, a really valid and relevant question. So it's with access to standardized instruments for autism and intellectual disability, which can be certainly time intensive and resource intensive for people, particularly people who aren't working in tertiary centers. And well, Dr. Ogilvy wrote is not accessible to all clinique in their practice. I assume that it's not talking about the cosmetics
Acne
brand.
treatment. Yeah.
But the, you know, I mean, Jacqueline, what are your thoughts about what you've asked, Jackie? Yep, go right ahead.
Thank you. Yes, sorry, I was typing on my phone, autocorrect. Well, I guess I was speaking to the thoughts and previous comments about us trying to use, an evidence-based approach to diagnosis, which includes try to triangulate and gather information from multiple sources and multiple reporters. But for autism, like for ADHD, we have some standardized tools and toolkits that are readily accessible, pretty easy to use in the community. And so you can kind of gather some of that data and then, to Peter's point, put it in context, and that's where the clinician helps make the diagnosis. For autism, there's a lot of great standardized tools out there, but they're all can be quite costly and can need some training in interpretation or even administration. So I don't know if we've, really done a good job in making sure that those ways of trying to gather that information in a standardized fashion is accessible in the way that it needs to be, so that we can be kind of coming to agreement and having that documentation, especially for those working in pediatrics. We can't do we need support or we need somebody else to do the psychology and IQ piece to really provide that fulsome assessment, which really happens at a kind of a finite number of places. So that's just my kind of 2 cents in trying to work with the young kids, especially because that is so important to the differential. And I think there's lots of work to be done to make that more accessible.
And Peter, do you have any thoughts about what Dr. Ogilvy was saying?
Yeah, I mean, I think ultimately I agree. I mean, the ADOS costs a fair amount of money to get trained in doing, and yeah, I mean, it's a barrier to pursue extra training to do something when a child psychiatrist who doesn't necessarily do the ADOS training or extra training in administering the ADI or doesn't follow it. I mean, it's not like that diagnosis is seen as less valid if they don't use it from a school board standpoint and a clinical service provision standpoint, even if they were to be used. But it would be really nice if those things were able to be included in training. Like from my perspective as a trainee, I mean, it'd be great to be able to do that as part of training and to be able to access it in a not cost prohibitive sort of way. The intellectual disability part and kind of IQ testing would be, I think, like a separate point, although related. And I think those are important problems that don't have easy solutions either. But I agree with the premise of your point completely.
But I also think, Peter, what's happened though is that the ADOS has become almost biblical in stature, and that sort of it almost causes people to have autism, because you can't have autism if you don't do the ADOS sort of thing. And I think any tool is only as good as the people using it. And I think there is a sense in some places, if I go out and spend whatever number of dollars on an ADOS kit and the manual, then I'm good to go. And I think it still requires that clinical experience. And even, the training that you're going to do next month, I mean, it's all online and it's not with kids. I think that makes it really difficult. And I think that what the people who make the ADOS, I think when it's done, you have to send in videos of yourself doing it, but it's only with people who have a diagnosis or who you diagnose. It's not people who don't. And so I think it's important to be able to diagnose autism, but also not autism. I think personally, there's no substitute for good clinical judgment. And my experience has been that among people who we see who we don't think have autism, I think who may have that diagnosis, I think one of the more common explanations is that people make the diagnosis, have done a lot of stuff with questionnaires and rating scales and not actually spent a lot of time with the kid. And I think we know from research that people with a diagnosis of autism, people with any kind of significant psychopathology in childhood are going to score high on rating scales for autism. I think that's been pretty clearly shown. And so if they're useful for anything, it's only to indicate that further investigation is warranted. They're not really useful for definitively making a diagnosis. They may be pretty good for ruling it out. But I think that becomes a problem, is that there are limited resources, as Jackie said, and so people want to do things in what they perceive as the most efficient way, but that may not always be the best way.
Yeah, I think that's a good point, particularly about the scales point. Yeah, I mean, it's easier to define in a pragmatic way that you can implement it with a scale ADHD symptoms than it is to describe the qualitative impairments of autism, because like the social communication questionnaire and these different scales that have been trialed out there, like, I mean, yeah, it's not like it's equivalent to the reliability of doing, yeah, whatever ADHD scale ultimately somebody uses in practice, but let's say the SNAP. Yeah, it's much harder to define these things in a scale that has good sensitivity and specificity and a balance of the two.
And positive and negative predictive value.
With 80% diagnostic reliability.
Yes, there you go.
Yeah.
I mean, so I think, you know, obviously, Peter, this has generated a lot of discussion, which is great. Are there other comments or thoughts that people had before we wrap up? Okay, so Peter, thank you again. This was fantastic. It obviously generated a lot of discussion, which I think says a lot about sort of the importance of this topic and the presentation you did. So thank you very much. By the way, we're on for April 29th or whatever that Friday was.
Yep. Yeah. No. Yeah, we're still on for your parole hearing. That still works well with my schedule. Yep.
The charges are going to be dropped. I'm pretty confident. But with the 3-year-old kid, and good Lord, that didn't come out right, did it? But anyway,
the combination of those two things would not land well. Correct. Yeah.
So thank you again, Peter. So our next presentation is next month. And off the top of my head, I hate to admit it, I'm not sure who our speaker is, but the date will be May the 11th. So watch your mailbox. And thank you everybody for attending. Please don't forget to fill out the evaluation forms that are sent to everybody afterwards when you log out. And if you have recommendations for any future topics, please feel free to say so, because I think it really helps us in asking speakers to join us. So thank you again, Peter. I think it was a fantastic talk, and thank you.
Yeah, thank you all for paying attention, and the fact that people did not fall asleep and sustained in like 30 minutes of discussion at the end is very much appreciated to get your perspective from my perspective as a trainee. So yeah, super helpful and very grateful for the opportunity. Thanks, Rob. Thanks the full group who attended and allowed me to speak.
All right, we'll see everybody next month. Take care.
Thanks.
And thank you, Dr. St. Pierre.